This morning I'm going to go over the latest program for the First International Mini Bypass 1 Anastomosis Bypass Consensus Conference to be held in Paris this October 18th, 19th, and now on the 20th. We've added a series of 6 to 8 live MGB surgeries that will be offered by Dr. KD's hospital in Paris. We'll be able to have between 3 and 6 surgeons observing directly in the operating room, and the operations then will be broadcast live to a conference room where we hope to be able to make available space for additional 20 to 25 surgeons. So we're setting that up, and we're happy to announce that. Looks like it's going to be a go-ahead for this morning. We're going to be talking about the program, and we'll go through that first in brief and then again in detail. The program begins on the morning of October 18th at 9 o'clock. The initial charge to the meeting will be from Dr. Chevalier. He will talk about listening, learning, discussing, voting, and then planning. And that's the goal for us, to address the mini bypass and 1 anastomosis gastric bypass, to come to a consensus from the meeting of this group of experts. One of the things we've determined is that although we include the world's leading experts on mini bypass and 1 anastomosis bypass, we also are flattered that a number of younger surgeons in the area of mini bypass, not necessarily in age, but surgeons who have had experience with the band, the sleeve, the Roux-en-Y, and now are interested in coming to this particular meeting because they're interested in the mini bypass 1 anastomosis bypass. And so we have two types of attendees, and so the meeting has been modified from a strict consensus conference of experts to include a good deal of basic discussions, technical issues for surgeons who are less experienced in the mini bypass and 1 anastomosis bypass procedure. The first presentation after the charge to the meeting by Dr. Chevalier will be by myself, Dr. Rutledge, and we're going to talk about recent research that shows from our survey, as well as from the medical literature, that approximately 30% of sleeve and band patients are reported to have gastroesophageal acid reflux following the procedure. And that is occurring even after relatively short-term follow-up in the sleeve patients. Remarkably, in reports from both the Netherlands and from Germany, 10 to 15% of sleeve patients within a few years of the operation are already proceeding to conversion to Roux-en-Y because of acid reflux. And what we wanted to point out is that there's an obvious relationship between acid reflux and esophageal cancer. So that if, like in the United States, the lap band has been done in hundreds of thousands of people, if imagine the sleeve were to continue its growth in popularity, we might have potentially hundreds of thousands or even millions of people with acid reflux, and we know that this is a precancerous lesion. We know that this results in progressive esophagitis, and followed this in a relatively logical progression to Barrett's, and so that esophageal cancer is a high probability in chronic acid reflux patients. So what this means is that surgeons and patients who are offering sleeve and bands to their patients need to consider this data, need to consider their own experiences, and potentially warn patients that these other operations, which in some ways are competitors to the mini bypass and the 1 anastomosis bypass for the choice of what surgery to choose in an obese patient, need to consider the long-term risk of esophageal cancer. And already reports are appearing of the band and the sleeve being associated with esophageal cancer. So it raises some significant concerns, and it's been demonstrated that reflux is a problem in up to a third of patients after both sleeve and band. Dr. Taha will talk about bariatric surgery, where we are now and where we're going. Then Dr. Manowar will speak about his review. He is in the United Kingdom in the Northeast area and has done, as part of his process of considering offering mini bypass to NHS patients, a literature review on mini bypass, and will be reporting basically on the literature review of the mini bypass and the results as published thus far. This will be followed by a question and answer period, some voting on some of these topics, and then we'll go to our special guest presentations. And here we're going to be talking and focusing on the story of transition from a non-MGB surgeon to an MGB surgeon. And we have two distinguished presenters, both former presidents of their national conferences on surgery for obesity. Dr. Nawaria is the former president of Obesity Surgery Society of India, and he'll be speaking on my journey to the MGB and the MGB and its present status in India. This will be followed by Dr. Chevalier, who is president of the Obesity Surgery Society in France, and he'll be talking about what I know about the MGB, 7 years experience and the transition from non-MGB to MGB surgeon. Following this will be questions and answers, and we'll be voting on some of the topics for the consensus conference statement on the floor, and then be going into the section 2, which is MGB, gastritis, marginal ulcer, and gastric cancer. This will be opened by Dr. Sirny from the Czech Republic. His title of his talk is My Ulcer Problem, the Czech Experience with Ulcers and Mini Bypass, the Appropriate Management, both preoperatively, intraoperatively, and postoperatively, as well as the general topics of gastritis following the mini bypass. We're happy to have the presentation of Dr. Wiener, and he'll be presenting his results and reports from Germany with a relatively high incidence of marginal ulcer with mini bypass. In his series, he's reported up to 15% of his patients requiring conversion to Roux-en-Y because of severe marginal ulceration, bile reflux. And so we'll talk about that and listen to his insights on this topic. Then I, Dr. Rutledge, will give a talk on bile reflux, gastritis, and marginal ulcer, specifically comparing my results and results of several other surgeons who show that the incidence of marginal ulcer in many other surgeons' experience who perform the MGB at high volumes show rates of ulceration and gastritis and bile reflux in the range that equals or slightly less than Roux-en-Y gastric bypass reports. This will be followed by Dr. Garcia Caballero, and he will in particular be talking about the specific techniques of the one anastomosis bypass. As you can see, every time we present this morning, we have the rather cumbersome description of the conference and the procedures as the mini gastric bypass / one anastomosis gastric bypass. Dr. Garcia Caballero's talk will be specifically describing the anti-reflux mechanism that is built into the one anastomosis bypass. And so we'll listen with interest to have the understanding of how this was initially designed and his results, which are really excellent now in over 1,000 patients in his leadership role in this development of the one anastomosis bypass. This will lead to a, I expect, spirited discussion from the floor, and we'll be working towards voting on this topic, although I don't think it'll be completed with this presentation. We then go into the technical performance section, section 3. This is opened with our colleague from Italy, Dr. Musella. He'll be speaking on both the Italian experience with mini bypass, but also on some specific technical performance issues. This is also going to be focused on by Drs. Paragli, who will speak about his best practices in the United States of the mini bypass. Dr. Ribeiro from Portugal will be talking specifically, focusing on some of the aspects of the gastric pouch in the mini bypass. Dr. Jan Alpers will be speaking on the Dutch experience with mini bypass and some of the details on the bypass and the anastomosis portion. And then this will be open to a general discussion led by Dr. Chevalier, Garcia Caballero, Taquino, Coular, Paragli, Nawaria, Weiner, and really looking into these technical details. In other words, we do have a large number of successful reports on mini bypass, but we also have some troubling reports of surgeons who've had high incidences of reflux and marginal ulceration. And so one of the things this discussion will talk about is technical performance and whether or not the Billroth-2 type connection is inherently unstable and leading to high rates of ulceration and demanding revision, or whether in fact the several other reports suggest that it's a very good anastomosis, it's a very useful technique, and rarely causes problems when done with specific approaches. And we'll talk again about specific topics like the length of the gastric pouch, the ischemia potential of the tip of the gastric pouch, and the particular focus on the Carbajo-Garcia-Caballero one anastomosis techniques. And so we expect, again, a spirited discussion on this topic. Lunch will be next, and we understand that a number of our surgeons and attendees are not experts in mini bypass, that they are here and have signed up and invested time and money and effort because they're interested in mini bypass. And so specifically to address their needs, their wishes, lunch is going to be offered on both Thursday and Friday, including technical videos by the experts. And so for the Thursday video conference, we're going to have Dr. Garcia Caballero spend additional time on the specific technical performance issues of the one anastomosis bypass, and I think this is obviously going to be of interest to all of us. Dr. Paragli, who really I can vouch has one of the most superb results in the world with mini bypass, will talk about his insights from his long experience as a master of the performance of the mini bypass. And Dr. Coular, who also is an internationally recognized expert in the performance of the mini bypass, will present a video. And each of these 5-minute videos will be open for discussion, but we have placed a very strong, rigid constraint on each of these experts. We said, give us 5 tips from your experience of hundreds and hundreds and many years of the performance of the one anastomosis or mini bypass. Give us 5 tips that you've learned that you can offer to the new surgeon. So we expect this is going to be exciting and really valuable opportunity. Thursday afternoon starts section 4, the long-term studies and other topics for the consensus conference. And here we'll have Dr. Mgb-Oa, who will speak on the role of the mini bypass, one anastomosis bypass, in comparison to other operative choices for bariatric surgery. While we think the mini bypass has advantages, it certainly has disadvantages, and we'll be talking and have talked about those things, but so do the other operations. And so what we want to do here is take a few minutes to begin to lay out the performance outcomes of the different types of operations with both risks and benefits listed. Dr. Jean Cady, a true international expert on the performance of the mini bypass, will talk specifically about the MGB as a rescue for failed lap bands. Dr. Cady has a huge experience, over 2,000 cases of mini bypass, and interestingly, over half of his cases are for failed lap bands. So this will be of particular interest to a large group of our surgeons who are going to be facing higher and higher rates of failed lap bands. We're then fortunate to have Dr. Coular. He will be speaking on his experience of hundreds of sleeve gastrectomy patients in comparison to his experience with almost 1,000 MGBs. Dr. Coular is particularly well suited to talk about this because he obtains routine follow-up upper GI contrast studies, and he'll be commenting on the dilation and failure of the sleeves that he's observed over the years following his over 200 sleeves. We're fortunate again to have an international expert, Dr. Roberto Tocchino. He'll be talking on his experience with mini bypass in Rome, again, which is very extensive. His skills I've had a chance to witness, and again, are superb. And his interest, that he has many things to tell us about, but we've asked him to talk about something that he has as far as a unique experience, and that is he has a significant experience in the performance of the BPD, or the bilio-pancreatic diversion. And so we'll look forward to his comments and discussion about the MGB, his outcomes and experience, his performance of the single site MGB, but most interesting to me, and what I pressed him to speak upon on this conference, is to talk to us about the comparison of the outcomes, in particular weight loss, complications, etc., of MGB patients in his experience and BPD patients. Very exciting, very interesting presentation. I think we'll all appreciate that. Then we have Dr. Peters. He'll be talking to us about the comparisons between the Roux-en-Y and the MGB. We'll have Dr. Mano, who'll be talking about complications and their management after mini bypass. Dr. Michael Vanden Bosch, who's done some really interesting research on the MGB in the United Kingdom, and will be talking to us about complications and management. And then I'll give a talk on leaks and the MGB. Particularly, we're going to focus on a very simple paradigm on how to manage and care for leaks. We're going to have kind of 3, 4, 5 things to take home. 1, a simple, short, safe surgery that has very little anesthesia, very little trauma, very little bleeding, will require very little pain medicine, post-op, very little sedation, and thus the evidence of a leak is much easier to identify. The way to think about this is an appendectomy type problem. If you have appendicitis and you have a patient taking narcotics or other things that might interfere with the diagnosis, then finding and treating the appendicitis early is more difficult. Because the MGB is a 30 to 60 minute surgery, there's less bleeding, there's less trauma, identification of leaks becomes much easier in the hands of an MGB expert. That means that post-operatively, if you receive minimal pain medicine, it's easier to identify a leak on the first several days. The second thing is we classify leaks and their management after MGB simply into 2 types: early, less than 48 hours, and late. And if they're early, you re-explore liberally, you don't do any tests such as ultrasounds or CAT scans or white blood cell count. A patient who looks abnormal with increased pain above the usual or other abnormalities such as tachycardia, you just re-explore. It's very easy to do, and that's what we strongly recommend. Re-explore, re-explore, re-explore. And if you find a small leak, it can be repaired routinely with a suture. If the leak is identified late, then what we recommend, again, is a very simple approach. Don't try and repair it, don't try to do anything special, but simply divide the gastrojay and do a gastrogastrostomy and drain the patient, place an NG tube, and that is routinely, easily technique to manage the leak after MGB. So I'll be talking about more research in detail on that topic. That's then followed by a general panel discussion. We'll have again Chevalier, Garcia Caballero, Tocchino, Coular, Paragli, Nawaria, Weiner, and Dr. Musella and Dr. Vanden Bosch will be recorders. And then that will be concluded that day with kind of the question of, if the MGB is so good, why don't people use it? And we'll be talking about irrational decision making, cognitive biases in the development and choices for humans as far as the decision-making process.